zoom on the X-ray or the CT.
Now take out what are not necessary things. Right?
Kaushik bhai, can you hear us?
Yes, I can hear you very much.
Yeah. So Rajesh wants, to have a look at the CT scan picture.
Okay. So you show the CT scan picture.
Yeah. So
Yeah.
when the audience logs in, the CT scan image should be ready. And yeah, perfect.
Aarti, we are waiting for you.
Yes, sir. We are live and attend this platform. Just confirming from Facebook and YouTube, sir.
Fine. We are waiting.
Let's see. So,
Yes, sir. We are on a live on 3 platforms, sir. On attendees link, Facebook and YouTube. So should we start with the introduction, sir? My colleague Keyur will be there. Yes, sir. So, okay. So 3, 2, 1. Over to you, Keyur.
Yes, thank you, Aarti. So on behalf of Lupin, I welcome you all in this E-Masterclass and live operative workshop. So today our workshop will be on Miniperc and Super Nephroscop, why and how, and live operative demonstration of Superperc with Super Nephroscope. So our extreme panelist, our extreme speaker is Dr. Kaushik Shah sir with us, who is MS gold medalist, MCH urology, and sir is consultant urologist and practicing at Surat. With this, I also want to introduce our moderator for this event, Dr. Rohit Joshi sir with us, who is a MS DNB urology, laser urologist, endourologist, uro-oncologist, and sir is reconstructive and transplant surgeon. I also want to introduce our moderator for this event, Dr. Rajesh Kukreja sir with us, who is consulting urologist and currently practicing at Eurocare Hospital, Indore. So with this, let me hand over this whole meeting to you, sir. Over to you, Dr. Kaushik, sir.
Kaushik bhai, we are live, so you can start. Yeah.
Okay. I welcome all the delegates and especially our faculties, Dr. Rohan, Joshi and Rajesh Kukreja, and thanks Lupin for sponsoring this and creating this event. The purpose is creating a master class in a slightly different way, where we'll be actually showing what exactly is happening. We'll show all the different equipments and we'll tell you what are the advantages, disadvantages, and we'll use one of them. Now coming to the case, we are going to do a PCNL for a small stone of around 12-15 millimeter. Now in the era of ESWL RIRS, here ESWL was not possible because patient had a severe colic and the kidney was obstructed. If you want to do a good ESWL, the kidney should be unobstructed. So that was ruled out. The Hounsfield unit was 1400. So that was also an adverse factor. Patient did not want a stent and it is a costly procedure for the patient. So we decided to go for PCNL. Now if you look, this is a, can you see?
Can we zoom in, please? Can we zoom in?
Yeah. So now this is the left kidney. So the patient has a left kidney where there is a stone. So as we go, we are able to see the upper right kidney because it is normally lower down and there is a hydronephrosis. Now the stone is seen, and if I puncture from here, practically there is no different callisis. It's all probably because of the distension. Can you see all these things? So anyway, puncture, and now this is the track. So there is no retrorenal colon, no liver, no spleen, no lung. So we can always plan surgery in such a way that adjacent organ injury can be prevented. That can be done very well on CM. Here also you are seeing this stone, and practically no other organs are coming, right? So this is how we have planned that we'll plan from here and reach the stone. Any other question? And I had done it normally in all cases. I do a sonography in prone position on my examination table. I have a sonography machine in my consulting room. I do sonography in all patients in prone position to see what is maximum access, what are the adjacent organs that can come. I can see the lung movement because when breathing, it is a lung that moves. That is a visceral pleura. Parietal pleura is always fixed to the chest wall. So in inspiration, parietal pleura cannot change the position. It's a visceral pleura attached to the lung that comes down or goes up. So,
Right.
so if you want to prevent a lung injury, you do a sonography in prone position in consulting room and see how far the lung is coming. And then you will be able to decide the exact track if you want to go for supracostal puncture. Yeah, that is not an issue. Okay.
Right.
Is this for the stone? Shall I come to the
Yeah, Kaushik bhai. Now let us focus on the surface view.
On
And could I
surface.
ask you how much is the Hounsfield unit of this stone?
1400?
Oh yeah.
So 1400 is too high, and therefore I have decided not to puncture. And of course, we needed a case for this. He was an ideal case, so we decided that we will demonstrate this. Now,
Can we have a look?
hello. Now I am showing you the surface view. All different instruments, different dilator, different puncture techniques. Everything is shown here on the trolley. So coming to the puncture needle, this is the two. Coming to the ureteric catheter, normally ureteric catheter has an opening only at the tip, but here we have an opening at multiple holes.
Right.
So if you have an opening at multiple places, what you can you see here? Now the fluid is coming from multiple opening. So
We got it. Yeah.
So if the stone is if the tip is in the upper calyx, all the parts of the PC system will get a fluid. It will not be filling from the calyx to the pelvis and going to the other. And you will be able to see the ureter, pelvis, and all the calyces simultaneously. And
Right.
it very well.
Equal distribution of the pressure in all the calyces rather than one calyx. Yeah.
Yes. So we have put a ureteric catheter. We had a slight doubt that it might be impacted stone, but fortunately with a new Terimo guide wire, it went in easily. Now coming to the puncture needle. Now this is a two-part puncture needle. This is very good for puncturing in a bullseye technique because the CM will come in. If you have a longer needle, it will be very difficult. So whenever you are doing a bullseye technique, you should select a short needle. And if you are doing through a triangulation technique, you should have a long needle. And it should be a two-part needle. And if you see here, it should match very well. Otherwise, the tip will not come inside. Can you close? Can you see the tip? Can you see the tip going in and coming out?
Yeah, we can see.
And the stone is touching the stone on still your inner cannula is 2-3 millimeter inside. So once you know, then you have to advance slightly in. Otherwise, this needle might be outside. So whenever you puncture, just push it in and then take it out. That is one point you have to remember. Second is there are many people who are using three-part needles. And the tip is here same. This is a useless needle. I am repeating, this has no advantage over a two-part needle. Right? And this needle has a evolution tip. So when you are doing an ultrasound guidance, I can get an echo where my tip has gone. So this is a good needle where whether you are doing sonography guided puncture or a triangulation technique, this is a very good needle. Now, if you want to use a three-part needle, the best is a Stowe's three-part needle. Now, if you see, this much part is a thin part. Can you see? Can you see? This is
Yeah.
yeah.
Yeah,
This much part is a thin needle. Now, when you are puncturing in the cortex, this much part is entering, and once you take the fluid, you advance this needle inside. So, repeated puncture, which is common in triangulation technique, this is one of the very good needles. Now, another company needle does have the cannula up to here. So, only this much part is outside, and it gives a very good stability. So, if you are starting, this is a very good needle. If you want to do a repeated puncture, this is a small puncture. So, 3-part needle should be like this. Now, there is another very good innovation by Dr. Ashish Patil. This is a 5-pen needle. Can you see one tip? Can you see one tip?
Yeah.
So that tip is one part. Then this is a second part, third part, fourth part, and a fifth part.
Right.
And there is no hub. So this needle, when it is there, you pass a guide wire, and over a needle, you advance all these 3 sheets one by one. So it would be seen like this outside. The advantage is that once the guide wire is in, or you have done a puncture, and if the guide wire is not coiling, you don't need to bother whether the guide wire is kinked or not. What is happening? The needle itself is working as a guide rod, and you advance all these needles, put a scope, and confirm. So this is very good for a closed calyx, diverticular stone, or when the stone is completely filled up and there is no space for the guide wire to go in. This is a very good needle in such cases. Or you want to heat a particularly stone bearing calyx with no space for the guide wire to coil in, right? So this is the needle. Now after puncturing, I'll come to the dilatation. Will that be okay? Hello?
Yeah. Please carry on.
Oh. So this is the needle I have told. So the needle part I have discussed. Now about the position. I am saying that this is a head end, this is a foot end, right? The irrigation channel is coming from the left side towards this side. Now I have attached an infant feeding tube, right? So now I am free to inject from here. So the control is in my hand. How much I inject, what I inject, and therefore it becomes very easy. Is it clear? This is my point. Now, can you see this tube?
Yeah, we can see that.
So this is a tube which I will attach to my suction sheet,
Right.
and this is going to the bottle. And any standard suction tube is going from here to a suction machine. So this is all what you have to put. That is all preparation you need if you want to do a suction with a superpuck sheet. Where is the suction machine? Can you see the suction machine?
Yeah.
Yeah, we can see that very well. Yeah.
Yeah. So you can put it there, and there is a suction bottle which we can empty, and there is a bucket. If you open the tap, it would empty. We'll show you when they are emptying the bottle. Okay.
Yeah.
And there is a knob, we can control the suction pressure. Can you see the knob?
Yes, sir.
This is a knob, this is on or off button, and here we are showing the pressure unit. How much is the pressure? So now we will start puncture. I am a good fan of triangulation technique, not bullseye technique. And I prefer Meriton's air pilogram. See, unfortunately,
Have you placed bolsters, Kaushik bhai?
no, I have not placed the bolster. I have placed bolster only below the shoulder, upper chest. Upper chest bolster is helpful to the patient that they can move their neck. If we don't put anything there, then it is very difficult for anesthetist to manage, and this bolster keeps the head up and there is no cervical problem. Otherwise, I don't put any bolster. There are many ways of putting a bolster. One can put a bolster here just below the abdomen, actual abdomen. One way of putting is below the lower chest and below the pelvis, and therefore the abdomen can hinge. Here, this is a female patient, and therefore this is hanging. So sometimes I put a bolster or a simple pillow in the abdomen, but this is the obese lady. I didn't wanted to put more, and therefore I have not done anything here.
No, Kaushik bhai, the patient is in GA or spinal.
It's under general anesthesia.
Now, what is the aim of putting bolster is that we need to take the pressure off. So that is why we need to put two bolster, one in the chest wall and one under the pelvic ring. So just clarify that thing for the audience.
I do not want to. I don't need a bolster basically.
The patient needs the bolster because your anesthetist might need the bolster because if you keep the patient just like this, especially when she or he is obese. Now there will be rise in the pressure. So the main contention of keeping the bolsters are different. Rajesh, your take on that.
See, the corona epidemic has shown that patients in prone position also have a very good breathing, and our anesthetist says that we are very comfortable.
No,
Oxygen
it is not a question of prone supine. Prone is always deficit. The perfusion ventilation ratio is always better in prone position. It is always
Absolutely.
better from ventilation and perfusion point of view. There is no confusion. We generally keep two bolsters. Reason being that the diaphragm gets easy space for the movement as the belly falls down, and so the
Right.
diaphragm respiratory excursions of the diaphragm are much easier. That is the reason why we prefer to keep the one bolster transversely below the chest and one transversely below the pelvis.
I
Perfect.
agree. Once you put out this bolster, if those who are not putting a bolster and making the patient prone, on if on turning the patient prone, if you see that patient is developing hypertension, it is a compression of the IVC, and you immediately turn the patient. Otherwise, patient will go in shock and arrest. So anytime if you are turning the patient, putting bolster, you always measure the blood pressure, what is happening, and if you find anything is abnormal, patient is hypertensive, suddenly becoming, without bothering anything, dismantle everything and turn the patient prone, supine, and that would save the patient and your day.
So Kaushik bhai, shall we take a message home that it is rather preferable to keep bolster to remain safe, right? Let us go ahead. Yes, sir.
I mean, it's a personal. Actually, our anesthetist said that respiration is not hampered by this position, and therefore he is not
Okay.
of the opinion. And
I'll
second
take your
thing,
point.
that if you put a bolster on both the side, the kidney becomes extremely mobile.
Right.
And those who are starting practice, the resistance comes at the capsule, and the kinking occurs.
Right.
Right. So, ideally, those who want to start PCNL, they should have an operated kidney so that kidney is not mobile and easy to puncture.
Right.
So, the excessive movement, if you keep a bolster, is not favorable for the beginners. Now, shall I go to the puncture part? Now, you are seeing the CM. I always keep foot seat control under my foot. Now, can you turn the CM? Now, this is reverse. Can you see what is happening? Completely. Can you see? I am turning the picture on the image completely horizontal. Aji, go more. Yes. Now go more. But now shift the CM towards upside. So I am able to see ribs also, upper calyx also, some part of the spine also. Can you come closer to me now, slightly? On the bus. So I am just seeing the spine. Are you clear? There are a lot of gas shadows. Can you see all the gas shadows? But they are gas shadow of the intestine, small bowel, the large bowel, because there is no holstration. Is this clear what I am saying? From the gas shadow, you may be able to say that they may be colon or they may not be colon. And we have seen that there is no retrorenal colon. Now I will tell the to save the screen. How say? Now I have two choice. Shall I put a air or put a contrast? I'll put an air. Right? Now see the air is. Can you see air has come? Hello? Are you able to notice air? And
Yes.
now I am withdrawing also. Now there are two places where the air is gone up. This is where there was no air before. This is another place there was no air before. Right? Can you see this area now? We have seen there.
Yeah, sir.
Yeah, correct. We can appreciate.
Now when there is 2 point, we have to find out which is a. Now remove this. Now, for those who are not able to understand what is anterior, what is posterior, I am just putting this. This is a stone, right? I am putting one ECG lead which is GTO done. Now, can you see ECG lead and the stone? Hello?
Yeah.
Yeah. Now, turn the patient, turn the CM. Can you see the movement of the posterior part towards the spine? Hello? Right? So, any
Yes.
structure between the stone and the ECG lead is posterior, and if the structure is seen behind the stone, it is the anterior. Right?
Right.
Okay. So, now there are multiple. See, previously we were not able to see this gas. Now the pelvis is full of gas, air which are injected. Now, when you are doing and injecting air, what is important that you should not inject more than 10 cc. And if the system is not showing that, that means either there is a leakage somewhere here or the air is going into the circulation. You stop it. You don't use an air, use only the contrast. So to prevent air embolism, you have to see that whatever air you put has to be seen in the PC system. If it is not seen in the PC system, you have to stop using air and use a contrast so that you can come to know where it is going. Right? Now,
Yeah.
now if see, this is a position. Now, if I am moving, I am moving the needle this way, the CM also is moving this way. Right? Can you see? It is one-to-one correspondence. I am putting towards the leg end, it is going leg end. If I am going head end, it is going head end. If I am going towards this side, it is going. So there is a one-to-one movement. So those who are learning, they don't have to think about where my needle is going. It is going exactly the way we have designed. Now, if you see, that is a very long rib. Can you see it is a very long rib?
Yeah.
This is the whole rib. It's coming right here, and this is 11th rib is coming right in the mid axillary line, almost up to that. Now we'll have to go in between the two ribs. Now, in bullseye, the tip of the needle and the target should superimpose over each other. You can start at the skin level, or you can start after going somewhere lower down. That now I am using my so I'll puncture somewhere here between the two ribs. I'll palpate that yes, I am in between the two ribs. And I'll just make a small puncture mark. I'll not put a big mark for dilatation. It is only for my skin puncture.
Are you puncturing in the 0 degree or the 30 degree?
It is 30 degree now.
Okay.
Show the surface up. Show the CM. Close the look. Are you able to see now?
Yeah, got it.
Now, in spite of showing this needle, when I am putting, the rib is coming. So I'll put another small puncture mark with the scalpel where Can you see this is, can you see here, focus? This needle has slightly come out. It should not come out, you should be like this. So when you're pushing, you have to push the needle and hold it like this so that this tip is always out. Are you getting this point? Hello?
Yeah, we're getting that point. Yeah.
If this is like this, you will not be able to puncture. It has to be in the slot provided. Now I am going in. Now I will keep following the air only. Right? See, I had gone too much. If I am getting a blood, I'll have to give me a syringe. I'll have to stop. I have to take out the needle completely and don't use this. I'll completely take out.
But this is too medial, Kaushik bhai.
Yeah, I got that point. I couldn't feel that feeling of giving way and I pushed too much. So I had completely taken out. Let's put a contrast. Give me contrast.
Kaushik, I would recommend to withdraw a bit. Though this is multiple.
Right? Hello?
Yeah, right.
So we have seen the ureter upper, and that is upper calyx where the gas shadow is there. Now I turn the patient CM. I'll select this part, right? So this is much medial. Now I'll take it 30 degree, 0 degree. I think I have reached there, right?
Yeah, looks like.
India karo. Right? Are you able to see?
No, we are not
Yeah.
able to. Your assistant is coming in between. Can we see clear urine coming?
Yes.
Can you focus, zoom on the needle?
Can you see now?
Yeah. We can
Yeah,
see
now
that,
it's
sir.
clear. Yes.
Yes. Perfect.
Perfect.
Now I'll put a guide wire. Now there are two types of guide wire. One is a straight tip and one is a J tip. If you think that you have gone in and came out, then use a J tip guide wire. And if you think that you are slightly superficial, use a straight tip so that it goes directly inside. Now I'm putting right now a J tip, straight tip. Now whenever I'm holding, I'll put my two fingers on the chest and index finger I'm holding like this. So this my little finger is stabilizing the needle and my foot is showing where my guide wire is going. Can you see? It is not properly going in.
Are you using?
Now I use it.
guide wire or a glide wire? Terumo wire or a
It's
guide
a
wire?
Terumo guide wire. Give me the tip. Can you see? Because I had gone in and come out. Hello. The guide
Yeah.
wire was not going, but because now I had used a J-tip guide wire. So the guide wire, instead of going to the opposite puncture hole, it is changing the direction. Are you getting my point?
Yeah, got your point. Got your point.
And this guide wire now has gone into the upper calyx, right? And then came back. So I'll just take out the needle. And before I take out the needle, I'll make a hole, bigger opening, because the wire is protected by the needle. So always make a opening when the needle is inside, right? Am I clear?
Correct.
Hello.
Yeah, correct. That's a good point. Yeah.
Now coming to the first dilatation, you have a multiple option. So the camera, this is the alkene cannula with needle. This is a screw dilator, and this is a Teflon dilator. If you want to put a second guide wire, alkene cannula is better. Am I right? So
Right.
I'll use the alkene cannula to demonstrate how you can put a guide rod and a second guide wire. Okay. So I am just taking out the needle. The assistant should hold the guide wire and then I should take it over. Now the assistant will give me a alkene cannula. But now I am holding the guide wire. Can you see? If I don't hold the guide wire, it will come out.
Yeah.
Now, once I leave it here, can you see my finger here? I am holding a guide wire.
Yeah.
Can you see this? So I am leaving this. And now any advancement would be under CM. So I will change the direction so that my needle is straight. Right? Hello?
Right.
Point?
Right, sir.
Now I will put the outer cannula in. Because there is an inner guide wire, it is well protected.
Correct.
Can you see it is not rigid? I can advance this also, right?
Right.
Now it is slide very easily.
Can you flush fluid from below and show that
The below. Flush from the saline below. Can you see the clear fluid coming now? Can you see the clear fluid coming? Hello? Are you able to see the clear fluid?
Yeah, we are able to see.
Push it again. Now I can use a guide rod. If I want to put a guide rod, I will put a guide rod. If I don't need a guide rod, I will not put a guide rod. So do you want me to put a guide rod or no?
I think you can put a Teflon dilator straight away now. Are you going to use Teflon dilators or you're going to use a alkene system?
See, now I want to demonstrate how to put a second guide wire because there is a lot of questions. So I'll put a alkene rod and a second guide wire and take it out. And then I may not use that alkene rod, I'll take it out. So to demonstrate the junior, I'm putting now the guide rod, right?
Okay.
Put the first guide rod. It is not coming out, miss. Now give me a second guide wire. Yeah. Now give me a second guide wire. Now second guide wire will pass by the side of it. Can you see? I am putting a second guide wire.
No, it's not seen. Can you show the CM again?
Can you see second guide wire also gone in the upper calyx?
Yeah, now it has gone in the upper calyx. You can see that, yeah.
It's following the same path, right? Now,
Yeah.
now what I'll do, I'll take out the alkenes cannula. Now I have a safety guide wire. Call kar do. And a guide rod. If I don't want to use a guide rod, I can take it out. Right?
Right.
So this is how you can use the guide rod, third and a second guide wire with third removing the alkenes cannula, because this is giving a safety to the track. Track will not be lost. Now, because I put a guide rod, I'll just show you how you can use the guide rod. Telescopic dilator, or I can use it. What do you want me to do? I'll put 18 French track size, so I can put straight away 18 also. So I'll take
Yeah.
out. I'll take out this guide rod on a over a. 18 of it. No, not this. Either I use one in between, or I can use directly 18. This is now I am sliding over a guide wire, right? And now I entered there. Can you see?
Yeah,
Right.
very well seen.
And then I'll push it. And I am rotating and taking out the obturator. Keep pushing. Why there is a lot of blood? Keep pushing. Now, when she is pushing, I will show you on this side the dilators, different sheets. Hello.
Yeah, we are with you. Yes, yes.
Keep pushing. So now there are Teflon dilators, right? Can you see the dilators?
Yeah.
So these are
Yeah, we can.
Teflon dilators which we can use, and then we can. So this is one way of dilatation. Second is a telescopic dilators. So these are two, and third is a Ampler's dilator. So this
Correct.
is a. So over this you can put it.
I think once we have, yeah, correct. Once if we have placed the sheath inside, we should proceed inside now.
Okay.
Yeah, Kaushik bhai, unnecessary. There will be some clots happening and all that. It will mash up the thing. So let us proceed with the intracorporeal thing. We'll discuss this thing later. Yeah.
I think once the puncture has been done, we should
Yeah.
not interrupt the
Proceed.
process. Yeah.
No,
Proceed,
I
proceed.
got
Yes.
some bleeding inside. Give me the scope. Not 16 French.
This is, I think, 13 French scope, correct, Kaushik bhai?
13.5. You keep
Yeah.
pushing.
13.5 and 0 degree.
I think there is some, though the urine was coming clear. keep the fluid on.
Yeah, now we would require endoscopy view. So whenever there is a possibility, give us the endoscopy view.
Ah. Can you see there is a vessel that is bleeding? Can you see?
Yeah, we
Hello?
can see. Yeah.
We just have to adjust your sheet little bit. It'll get.
Yeah.
Now the guide wire was you are able to see the bleeder vessels. This is another vessel, and
Yeah.
I think something unusual has happened. Even though the guide wire has gone into the palate, that was what we felt. But
I don't think we are in the system. Are we? That's the underdilatation probably.
Might be, yes. I am able to see the ureteric catheter. Can you see?
Yeah. That was an underdilatation. Now you're gone in.
Right.
Now you can advance that sheet beyond that bleeder, and then we can get the things clear. Yes.
To advance the sheet. Now
Perfect.
Now what I'll do, I'll withdraw the scope. I'll see the sheet and under vision I'll advance, or I'll put a guide wire here, and under that guidance I'll advance. Otherwise, it will give a code through a picture.
I think your guide wire is coiling here and there, so I think you better get the guide wire out and then do it, sir.
So I'll take out now the guide wire through which I had gone. I'll put another guide wire.
Yeah, and you pass it across the UP junction down the ureter, and then preferably then you can do that thing. Yes.
So you give me the same guide wire or another guide wire. How is the end of picture? We have been able to see the vessel bleeding also very well. Can you notice that part? That when it was under dilator.
But it is always preferable to under dilate than over dilate, sir. So we are good. We are good.
That is a very important point. Under dilatation is preferable over over dilatation. You can rectify. You can rectify. Yeah.
So now I am through that instrument channel. I am advancing the stone is so much infected that it may not go, but I think it has gone. CM, show the CM picture. See it. Sari taraf long. Take it towards you. Yes. Can you? Panning movement. Can you see the guide wire is going down?
Yeah.
So this is a correct guide wire properly placed, and over that I'll pass my dilator. Now I am able to see the sheath also. So I may not remove, but I'll just advance like this by rotatory movement, and I am in. Right?
Perfect. Yeah, perfect. Very well done.
So the advancement of the sheath should always be under vision and
correct,
not other way around. So I am advancing the sheath. Now, if you see the urine return is coming clear, can you see? I am going again and repositioning. Once my sheath is inside, it should not bleed. Am I right? It should stop bleeding. I am just again repositioning. Keep the laser. So now I advance the sheet near the stone. Now I do not want to leave this guide wire in the system. The purpose of guide wire was to advance the sheet in the system. So I'll just take it out, right? And that taking out is under vision. Now I'll attach my suction master. Give me suction master. Push from below. Now this bleeding is probably other than the track bleeding also, because it is coming significantly. Start the suction. Laser fiber. Can you see very hard stone? The picture is not similar. Hello. Picture is right.
No, we are able to appreciate the stone.
Right, and it is a hard stone.
Yeah. So what laser settings are you using now?
1/10. This is a thulium fiber laser. 60-watt machine. Now the instrument will always come from 6 o'clock position. Can you see the fiber coming at 6 o'clock?
Not yet.
Not yet.
Can you see that red tip?
Now we can see.
At 6 o'clock. At 6 o'clock. I am changing. I am moving the tip. If I come out, you will be able to see also. Can you see the blue? Irrigation height. Can you see now? Can I start breaking the stone? Hello? Are you able? 1/10. So I am breaking the stone, right? 1 joule and 10 frequency. Shall I start?
Yeah, please.
Can you see the suction has pulled the stone? So I am just withdrawing so that the big fragment. I will withdraw up to this and then I will go again.
Right.
It was an impacted stone. Both of you are an expert laser surgeon. So you can give a comment of what should be the setting and how you can.
While
do
you
that.
are while you are fragmenting and using suction, is the assistant nurse pushing saline from below?
No, right now, no. It is coming only by gravity. But because that stone has come, you can see that it is at the tip. So I am taking out.
Right. Kaushik bhai, regarding this
Yeah.
setting, see,
Here
whenever
is, if you close, the suction is on. I'll show you here. So if I use the suction, everything will be sucked. Now that blood clot is covering the stone. I am breaking from within because the stone is very impacted and it is not possible to fragment from outside in. So in a kidney impacted stone, you should start fragmenting from inside. Are you able to perceive what I am saying?
Yeah.
Yeah, I should keep the laser firing away from the mucosa.
Yes, that is important. So I am not touching I am rotating my laser fiber. That's how it is possible with this scope, with your fragment. Now, if I feel that some stone, I can do like this so that it separates from the mucosa and then it is coming off its own. I don't have to say anything. And once the stone is there, I just withdraw. Now this is another stone. Are you getting my point? So you need not use a dusting mode also in PCNL when you are using structure. Can you see now? Practically, there is one small piece that has also come off. Will come off. So I'll now put the laser on standby mode, take out the wire and see what is happening. Can you see all the stones? This big stone, hard stone, just came out without use of a forceps. And whatever the fragments are there is also coming out. And I am not taking out the scope completely. I am just stopping here and then going in. So it gives a very comfortable position. I have failed to understand the bleeding after I had taken out. Might be that the 15 was severely inflamed edematus. Otherwise, under dilatation will not produce bleeding after the sheath is placed in the position.
So can we have a CM picture just showing stone clearance?
CM. Now I don't need a second guide wire, so I can take out second guide wire. I can leave it there also. CM. Can you see the CM?
Yeah, we can.
Full CM, full CM. Make a full CM. Right? Okay. Here?
Yeah, it's perfect, sir.
I don't know what is happening. That wire is broken. What is moving? Huh? So it's
I think you had kept that ECG lead or something on that black spot. Can you remove that?
what is there? Now this is my guide wire that is seen. Otherwise, that is the ECG lead, I know. But I was feeling that why there is a piece. But then I realized that this was also looking like this. Are you getting my point? This is a wire through my endoscope. I have taken out.
Yeah, but safety guide wire is there, na? So that is a safety guide wire.
The safety guide wire which you are seeing going into the upper canal.
Yeah. Take that out also now. There is no need. Take the ECG lead also. So all these unnecessary foreign bodies are out. Yeah.
I have taken out.
Yeah.
Right. So now there is no stone. Right.
Perfect.
End of picture. अभी ECG lead मैं निकाल रहा हूँ, ठीक है? I don't need this.
Yeah.
So this posterior reference mark. Can you see ureteric catheter? Hello.
Yeah, we are listening to you. We are listening. We are on with you.
Can you see the laser mark on the ureteric catheter?
Yeah, we can see that. Yeah.
So this is not a catheter which you should leave at the end of a procedure. So, and because this was impacted stone, I'll put a DJ stent. Right?
Yeah.
If there been no bleeding and not impacted stone, I would have left without a DJ stent, only ureteric catheter. Now, give me that new Terimo guide wire.
I think a DJ will be better because of the mucosal edema. We can see it
There's some edema. And might be that this ureteric catheter has come through the false passage, or we don't know.
It seems like that. It seems like that, a bit of, yeah.
So that might have produced some bleeding also. We don't know.
Yeah.
Can you see the false passage?
Yeah, we can appreciate.
So the quality of vision is such that if very minor changes we are able to pick up.
Yeah.
For the first time we could see the bleeder through the undilated tract.
Yeah. Could we retract the ureteric catheter below that supposed to be false passage, sir?
So I'm going to retract that.
Please withdraw. Please withdraw. Yeah.
You can,
But right now, I want to put one guide wire by the side
yeah,
of it, and then I will
correct. You should put an anti-grade guide wire into the ureter.
guide wire, and then I'll withdraw that.
You can have a CM picture side by side.
CM. See, this is again a false passage. Can you see? Hello?
Yes, sir. Because of the edema,
false-
this issue is so
that is
variable that, yeah, that
This
everything is.
also going through the false passage. I am
Yeah.
withdrawing the guide wire.
That is precisely why I was requesting you to, withdraw ureteric catheter, give little space, for there is nowhere to go down. Yeah.
It's so fragile.
Yeah.
That soft tip of ureteric, this also. Now take out the ureteric guide catheter.
Show the CM.
Now,
There is a tissue coming in the camera. We can't see where the wire is going.
I'll just confirm that it has reached the. Take it out.
Can we move the CM down towards the bladder? See where the wire is going.
Now it has coiled into the bladder. Can you see it has coiled into the bladder?
Yeah, very well seen.
Now, give me a forceps. I'll take out that small tissue that was flopping.
I think better not to just leave it. It will go away by itself.
Now I'll put a stent here first, and then I'll try to take out the clot. Right? So give me a stent, 5 French.
So will the 5 French stent go through your scope?
No, it will not go. It will not go. I'll have to.
So you'll withdraw the nephroscope and put it under fluoroscopy guidance, correct?
Yes. So what I'll do, take out. Now I'll see again, and if there are small clots, I'll take it out so that this clot do not intercept the. Now give me the stent. Give stent. So I'll do under flow CM guidance. Now, right? Are you able to see the CM picture now? CM and surface. CM and surface.
CM is, correct. Now the surface is there.
I mean, how get up with you? No, no, sir. Now I am pushing this.
So you are not using this, you're not passing this across your scope.
No, because the separate instrument channel will not allow 5 French urate like this.
So that is a disadvantage. See, probably if I will be using my Miniperc nephroscope, I will put it under vision. That's a bit of disadvantage in this.
No, it is a disadvantage.
Yeah.
What is the channel? What is the channel size of your instrument?
Channel size?
Channel size is 4.8.
Why you use you can use 3.8 French DJ stent. I usually use now 3.8.
Yeah, now the DJ stent has gone in. I am taking out the guide wire. Right?
Yeah, it's coiled. It's getting coiled. Yeah, it's coiled in the bladder.
Yes.
Kaushik bhai, you can use 3.8 French DJ stent now. That can pass through this channel.
Yes.
So
That is a very
more secure.
It will be more secure. Now we are able to see
Yes.
the stent well in position. CM up.
You can actually use a 0.025 wire and then pass the French stent.
Now the upper end is also well placed, well positioned. There is a clot. I'll just take out because the clot will not come out with the suction because it is added somewhere. So I am passing a forceps.
So for postgraduate student, when you hold a clot, you need to rotate the forceps so that the clot comes in toto. Otherwise, it will just break away.
This is what I am doing, right? As you have suggested, right? I am rotating the forceps with a cloth. So everything is coming out, right? This is what you are saying, na?
Yes, correct. That's what I'm saying. So can we have the Siam picture of the upper the kidney showing the stent properly placed?
Can you see here? Are you able to see now CM picture?
Yeah, perfect.
Now I'll try to push the now properly positioned stent,
Yeah,
right?
correct, sir.
So this is
Are
a
you
calyx.
are you going-
Calyx. Can you see? Can you see a calyx? This is a calyx. So now
Are you going to keep a nephrostomy or a tubeless procedure?
what do you suggest? I think there is no need of putting a nephrostomy.
Yeah, a tubeless procedure is better. Yes.
So I'll just bring out and then tell more about the scope and the sheath, right? I'm just bringing out.
We can shift to surface camera now.
Yeah, surface camera. Can you see the bleeding coming?
Yeah,
The moment we put for some period of time, 2-3 minutes, it will stop. But
perfect.
when
It's a matter of compressing it for a couple of minutes. Yeah.
right, he is compressing, and then I am showing to the sheath part and the nephroscopy part, right? Hello. So, are you able to see the trolley now? Light on, light. Trolley.
So Kaushik bhai, show us the nephroscope and describe us the scope.
Yeah, this is what I'm showing. Right now, first I'll show the nephroscope. This is a nephroscope which is 16 French and it is a 6 French channel. Can you see? Hello.
Yeah, we can see. Please go on.
There is a chip, there is a channel, and rest the fluid is coming by the side of it. Now there is a straight
So the important point is that fluid doesn't come from the working channel, it is by the side. So even if you put an instrument, it will not stop your irrigation.
yes. Pneumatic probe. Where are the pneumatic probes? So suppose all pneumatic probes. Wait a minute. Where are the pneumatic probes? Bring the trolley. See, these are different size of pneumatic probe. Can you see now? Those who are not having a laser, they can use. Suppose this is a pneumatic probe of 1.8. This is a 16 French, and it is going very easily. And it's coming out through the central channel. Now, this big pneumatic probe of 1.8 mm can break any big size stone very easily.
Kaushik bhai, Can
Yeah.
I suggest you something?
Yes.
You attach the irrigation fluid, and then you show the flow, and then you insert this probe, and then you show the flow for the sake of understanding that even if there is instrument, the flow will
That is,
remain. Yeah, please.
now give the irrigation bottle.
So that is the trademark of this
Yes.
particular instrument. Yeah.
Yes. Give me the irrigation bottle. पानी चालू करो. Give me this. Give me this. हाँ. आवाज लगा दो. Attach another bottle. हाँ कड़ी ने लगाओ. Anyway, it's all right. It's all right. It's sterile, na? Take minute. Till that time, you can show the surface view. Here. Hello.
So Kaushik
Yeah.
bhai,
Yeah. Can
Kaushik
you
bhai,
see? There is no bleeding, right? Hello.
Kaushik bhai, there's a question in your chat box from Sumit Maskar. What is the suction pressure you need to keep?
So what is there?
Suction pressure you need to keep.
100 to 150 centimeter of water. 100 to 150 centimeter or 0.01 to 0.015 megapascal.
So do we have a didactic, or a designated section for this, or routine section machines of our routine will work?
No, I had measured this, and what is important, I will show you. So that also, okay, how you should maintain the pressure. Here there is a speed meter suction machine. Shall I test the first this?
Yeah.
Now this is a suction machine, right?
Right.
Right? Can you see here?
Yeah.
Now I'll attach one tube. Any one tube. Now I am attaching this pressure, right? Hello? Are you
Yeah.
able to see now? Put water,
Yeah.
plain water. Put water.
I think we can zoom out a little bit so that everything is seen.
I come. Away, suction on. Suction on. Can you see the pressure here? Rotate करो. हमने देखा है रीते करो. Can you see the dial moving? Hello. Can you see dial moving? Now I am clamping this. I am clamping this. Can you see the pressure rising? Hello. Take it. Can you see the pressure rising here?
Yes, we are appreciating. Yes.
I had clamped the catheter. I have the suction tube. So
Okay.
after clamping, you see what is the pressure. Here you can see 0, 100, 200. So this is where you should keep it. Now I am keeping it open. So when I am using this, here the fluid is being getting sucked out. Can you see this? Can you see the fluid getting sucked out and it's falling there?
Yeah. Correct.
So after clamping, you see that it comes to around 100, and then
Right.
each use, everything will be sucked out very easily.
Right.
It's clear? Now coming to the point of this. Check out the suction. Now I am attaching a nephroscope. अब वाला nephroscope खसेड़ ले एक बाजू. Now this is a nephroscope. Now I am opening.
Right.
Can you see the amount of fluid going?
Yeah, we can see
Now I am putting this big
instrument. Yeah.
and it is remaining the same.
Yeah.
Right?
Perfect.
Yeah,
Perfect.
very well demonstrated. Very well. Yeah.
If I use a other smaller scope, 13.5,
Hmm.
give me 4 steps. This 4 steps of
So, for the attendees, this is the beauty of the chip on,
showing. See the pressure again.
Yeah. Yeah, sir.
You reduce the irrigation height, and I am putting a forceps. There is no change. See, even with this low pressure, can you see?
Yes,
It
sir.
is at this height. It is my shoulder height. So here. Then also, it is an extremely good flow.
Correct.
And even if I put, so the amount of pressure required is not there. You don't have to use the irrigation pressure. You can reduce still further. और नीचे करो. Hey, नीचे करो.
Got your point, sir. Perfect.
थोड़ा ऊपर. Right?
Right.
30. Then also there is a good flow. This is a beauty. In spite of irrigation separate instrument channel, the flow is excellent. Right? Now we have another big nephroscope, which is 19 French.
So what is the working channel in the 19 French scope?
Is 9 French. See, this is a big forceps. It's going very easily. 2.5 M probe. Big limit. Bigger than this. ये बड़ा मुकिला pneumatic probe में क्या मुकिल है? Yes, can you see this big probe? This is 2.5 M probe. This is a 19 French and it goes very easily.
Right.
So any big size stone can be broken and this 19 French sheet can go through 24 French very easily.
Right.
And in spite of this sheet going, there is a lot of space by the side of it. This is 21. Give me 24. Open. You're not anything. Hello. Can you see the space by the side of the nephroscope?
Right. Right.
So all the fluid and fragments will come, and when you want to withdraw, just withdraw. Right?
Right.
This is about the nephroscope. Now I am talking about the sheet. Come on this side. Right, Abaju. Now the main component of the sheet is primarily the sheet and the dilator. Are you able to see that?
Yeah, we can see very well. Yeah.
Yes. This goes over a guide rod. So once it is in the system, I take it out, attach a connector. Here attach a suction tube, and this is to control the suction pressure. Now, these connectors are coming in different sizes. Can you read Excel? These will allow even 21 French nephroscope. I'll show you. This is a 21 French dilator cannula. Right? Can you see 21? This size nephroscope can go easily. So whichever size of nephroscope you have, accordingly there are different connectors. XL, L, there are different, and very small is S. This is M. And one more is L. So there are 4 different sizes of connector. Okay. Now, someone wants, I am doing, these parts should not come in the picture. So we have designed this way, which we have used. This is a 15 French. It goes over a guide wire. This is 12 French. This is very good if we want to use a second track puncture. Through this, we can put a standard Miniperc nephroscope. This is the Miniperc nephroscope. Right? This goes easily. So, our aim of second track puncture is to break the stone and put the stone into the renal pelvis. We don't need an outflow here. So, we can use the second track with a 12 French also, 15 French, 18 French, depending upon the choice. Is this clear? Hello?
Yes, sir.
Yeah. Understood the concept. Yeah.
The second thing is that my favorite nephroscope is the old half moon nephroscope. Can you see this?
Yeah.
This is very good nephroscope. There is a central guide wire channel. Put it there. Now there is a lot of space for the fluid to come out here also. And there is a separate instrument channel here. And the fluid comes out here. So this is very good for the bladder stone. You put this and complete the procedure, and because the fluid is coming out through here, the bladder will not get distended. Are you getting my point? Hello? This is something like a morpholoscope. Hello? Hello? Hello?
Yes,
Are
sir.
you?
Yeah, we are listening to you. Yeah.
Okay. So we have a different sizes of sheet. This is a standard Miniperc sheet. This is the Ampula sheet. And our aim is to replace this sheet. If you use this sheet or a Miniperc sheet, there is no difference. It's same. But the moment you attach this, it becomes a suction. If you do not want to attach any suction, you just attach a tube and all the fluid will fall in the bucket. So the whole field will be very clear. You can see here, so there is no fluid spilled on the ground. Can you see? There is no fluid. So what is completely clean, right?
Perfect.
Any questions?
Excellent demonstration, Kaushik bhai. Excellent demonstration. Great job.
Thank you. Because of the congestion, there was a bleeding, and because the pelvic system was so bad that even the ureteric guide wire over a new guide wire catheter also went through a submucosal passage.
Yeah.
Have you realized this issue? That is the
Kaushik
reason.
bhai, let me ask you a question. What sheath you were using this today?
Pardon?
What size sheath you were using?
I
I
think it was
used an
18.
18 French. I had used
Okay,
an 18
and-
French sheet
Okay.
and 13.7 nephroscope.
Okay. Perfect. So it was hardly a matter of 5 minutes the stone got out. So
Yeah.
fantastic demonstration, Kaushik bhai. You need a Saturday evening rest. Go home and enjoy.
Okay, thank you very much.
Okay, thank you very much.
Thank you so much. Rajesh, let us take this opportunity to congratulate Kaushik bhai for an excellent demonstration, and need to thank Lupin people also for supporting this initiative. Thank you so
Sure,
much.
I'm with you, Rohit. Thank you.
One question. Rohit
Thank
and Kukreja. One question. How was the transmission, quality of transmission?
Very good, very
Excellent.
good. All 3 cameras very well went up. Yeah.
Chinmay, thank you so much, Chinmay.
Okay. We have
Kaushik
created
bhai, Kaushik bhai, we need to have these activities more frequently. Many postgraduates would benefit from this, and those who are starting PCNLs. Yeah.
Okay. Thank you very much.
Thank you. Shall we take your leave, sir?
Yes. Thank you very much.
Thank you.
For
Bye.
everyone. Bye.
Thank you. Have a nice weekend. God bless you, sir. Bye, sir.
Thank
Bye,
you. Thank you.
bye.
Bye, Rajesh. Yeah.
So with your permission, shall we close it?
Yes.
Okay. So
Okay,
thank you very much.
okay.
Yeah, thank you. Thank you very much. So from here, I'm ending this meeting. Thank you.
Thank you. Thank you.
Thank you.
અરે અહીંયાથી બધું બદલી કેમ કાઢ્યું તમે લોકો